So, when you look at most joints in the human body, there's a certain, I don't know, predictable, robust architecture to them.
Oh, absolutely. Like the hip joint.
Exactly. The hip, it's a deep, secure socket. I mean, the femoral head is practically swallowed by the acetabulum.
Yeah, the bony anatomy alone gives you a massive degree of intrinsic stability. It makes perfect mechanical sense.
Right, it makes sense. But then you pan up, you look at the shoulder, and you realize evolution has made this massive, almost reckless compromise.
Or reckless is a good word for it. Yeah.
We've completely traded structural stability for an unbelievable, almost ridiculous range of mobility.
It's true. It is essentially, well, you always hear the analogy, it's a golf ball sitting on a golf tee.
A very flat golf tee.
Right, a very flat tee, held in place by a remarkably delicate web of soft tissues.
And welcome to the deep dive. Today, we're taking that golf ball, looking at exactly how the human body keeps it perfectly balanced on that tee, and more importantly for your exams, exactly what happens when it violently falls off.
It really is the ultimate anatomical trade-off. I mean, because the shoulder is the most mobile joint we possess, it just simply can't rely on deep bone-to-bone congruency.
Because if it did, we couldn't reach over our heads.
Exactly. We wouldn't be able to throw a ball or reach a high shelf. So instead, it relies on this highly coordinated relay team.
A relay team? I like that.
Yeah, it's a dynamic living system of ligaments and muscles where, each individual structure is designed to do a specific job, but only at a very specific moment.
And in a very specific anatomical position.
Precisely. If one runner drops the baton, the whole system fails.
And if you're listening to this right now, we know exactly why you're here. You're preparing for the FRCS Trauma and Orthopaedics exam.
The big one.
Yeah, the big one. And you're likely commuting. Maybe you're doing the dishes or, sitting in a busy on-call room trying to sneak in some revision.
You're distracted.
Exactly. You're distracted and you can't take notes. And honestly, you don't need to. We're going to do the heavy lifting for you today. Our core focus is shoulder instability.
Which is a topic that can easily feel like this dense labyrinth of acronyms and eponyms.
Oh, totally. The overlapping clinical signs are a nightmare.
But we're going to build it from the ground up, logically and methodically. We're going to repeat the high-yield facts so you don't have to rewind your player.
That's the promise. We're going to state every exam trap, every specific ligament, and every exact anatomical position twice.
Your only job is to listen, visualize the anatomy in your mind's eye, and just let the patterns sink in.
Because there is a master key to answering shoulder instability questions in the FRCS. It's not about the brute force rote memorization of 100 random facts.
No, not at all. It's about understanding a map.
A map. Shoulder instability is essentially a geographical map of positions and ligaments.
Right, so for every single position you put the arm in, one specific structure acts as the primary check crane. It steps up and becomes the primary restraint.
And if you change the position of the arm, you fundamentally change the mechanics, right?
Exactly. A different structure takes over the work. Position in, ligament out.
So if you can simply visualize and memorize this position of ligament map, you can conquer half the shoulder instability questions on the exam completely cold.
You'll literally just read a clinical vignette, identify the position the arm was in during the trauma, and you'll instantly know which structural tether failed.
So we're going to map out those exact arm positions and the ligaments that guard them. But before we get to the granular details of the capsule ligamentous complex, say that 3 times fast we have to zoom out.
We do. We have to divide the shoulder's entire defense system into 2 distinct, non-overlapping families.
The static stabilizers and the dynamic stabilizers. So let's cleanly separate these two. Talk me through the first family, the static stabilizers. What exactly makes a structure static?
So the static stabilizers are your passive structures. Think of them as the architectural scaffolding of the joint.
Okay, scaffolding. What's included in that?
They include the glenoid labrum, the joint capsule itself, the glenohumeral-ligaments, and importantly, something candidates often forget, the negative intra-articular pressure within the joint.
Wait, pressure is a stabilizer?
Yes. But their defining characteristic is that they hold the joint together without doing any active mechanical work. They don't have motor units.
Right, they don't contract.
Exactly.
Yeah.
They simply exist at a fixed length, and they only tighten and engage when the joint is pushed to its absolute anatomical limit.
So they're basically the safety net. The static stabilizers are the passive ones. the glenoid labrum, the capsule, the glenohumeral ligaments, and the negative intra-articular pressure.
Spot on.
And let's quickly touch on that negative intra-articular pressure because that's essentially a vacuum effect, right? Like two wet panes of glass stuck together.
That's a perfect analogy. The synovial fluid creates surface tension, sealing the joint, and providing a surprising amount of baseline stability just through, well, physics.
For physics, yeah.
It's a closed, sealed system. Puncturing that capsule, say during a diagnostic arthroscopy, instantly eliminates that negative pressure.
Oh, wow.
Yeah, it instantly makes the joint marginally looser, but again, it's passive. It is a static stabilizer.
Okay, so that's the static side. Now, what about the dynamic stabilizers? If the statics are passive, the dynamics must be doing the heavy lifting.
They absolutely are. The dynamic stabilizers are the active structures. These are the muscles.
The ones actually firing.
Right. Firing, contracting, adjusting. They are constantly working to compress and center the humeral head within that incredibly shallow glenoid socket throughout the entire arc of movement.
And there's a specific term for that.
Yes. We call this mechanism concavity compression. And when we talk about dynamic stabilizers in the shoulder, there is one absolute star player, the rotator cuff.
The rotator cuff.
The rotator cuff is the primary dynamic stabilizer. The biceps muscle, specifically the long head of the biceps traversing the joint, also plays a role, but it serves strictly as a secondary dynamic stabilizer.
Secondary. Okay, let me use an analogy to try and lock this in for you as you're driving.
Yeah.
Imagine you're driving a car down the motorway.
Okay, I'm with you.
The static stabilizers, so the labrum, the capsule, the ligaments, those are your seatbelts and your airbags. They're entirely passive.
Right, they just sit there doing nothing.
Exactly. They do nothing while you drive until the exact millisecond of a crash, at which point they pull tight to their fixed length and stop you from flying through the windshield.
That's great.
But the dynamic stabilizers, the rotator cuff, that's the active steering system. It's making micro adjustments every single millisecond, pulling the car left and right, keeping it perfectly centered in the lane so you never hit the crash barriers in the first place.
That's a highly accurate way to visualize it. The rotator cuff's job isn't just to rotate the arm, it's to provide that concavity compression.
Right.
It's constantly steering the humeral head, compressing it directly into the center of the glenoid concavity, keeping it away from the ligaments.
Now, I want to play the role of a highly stressed, sleep-deprived candidate sitting in the exam hall.
We've all been there.
We really have.
Yeah.
So I'm staring at a multiple-choice question. And the question asks, what is the primary dynamic stabilizer of the glenohumeral joint? And option A is the glenoid labrum. Now, in the heat of the exam, under time pressure, why is it so incredibly tempting to guess the labrum as a dynamic stabilizer? Because I know a lot of smart registrars who fall for this.
It is a brilliantly constructed trap, and the examiners use it constantly because they know exactly how the stressed surgical brain works.
How so?
Well, candidates know inherently that the labrum is incredibly important. They know that when the labrum tears, the shoulder falls apart and recurrent instability sets in.
Right, it's a huge deal.
Exactly. And because it's so functionally crucial to the joint's survival, the candidate's brain conflates the concept of crucial with active work. You read main dynamic stabilizer, your eyes lock onto the word main, you see labrum sitting right there as option A, and you click it because you know the labrum is vital.
You think, well, the labrum deepens the socket by 50%. It must be the main thing doing the work.
But it's completely wrong.
Because the deepening of the socket is just architecture. It's a chalk block.
It is completely wrong. The labrum is a static structure. It's a fibrocartilaginous ring. It does not have actin and myosin filaments. It does not contract.
Right, it just says that.
Therefore, it cannot, by definition, be a dynamic stabilizer. The exam will try to trick you by offering the labrum as the main dynamic stabilizer. You have to be disciplined.
So when you read dynamic, you must immediately think muscle.
Yes. Think muscle. And the most important muscle group is the rotator cuff.
Okay, let's obey our repetition rule for this audio deep dive. We're going to state the difference between the two families twice to make sure it's permanently carved into your memory.
All right, first time. The static stabilizers are passive, holding the joint without active work. They are the glenoid labrum, the capsule, the glenohumeral ligaments, and negative intra-articular pressure.
Yeah.
The dynamic stabilizers are active. They are the muscles. The rotator cuff is the primary dynamic stabilizer, and the biceps is the secondary dynamic stabilizer.
And a second time to lock it in. The static stabilizers are passive, requiring no active work. The glenoid labrum, the capsule, the glenohumeral ligaments, and negative intra-articular pressure.
Good.
The dynamic stabilizers are active. The rotator cuff is primary, and the biceps is secondary.
That is the foundation. You just cannot proceed to the complex pathology if you get those confused.
Which brings us to the end of our first topic. And for every topic today, we're going to conclude with our one thing rule, the absolute bedrock fact you take away.
If you only remember one thing from this topic, the rotator cuff is the primary dynamic stabilizer. The labrum, capsule, and ligaments were all static.
Perfect. Now that we know the ligaments are the static stabilizers, the passive seatbelts of the shoulder, let's move to the map.
Yes, the map.
Let's map exactly which seatbelt engages in which specific arm position. This is the glenohumeral-ligament restraint table.
This right here is where the real exam marks are won or lost. If you know this table, you can reverse engineer almost any clinical presentation they throw at you.
So I want you to walk us through the 4 heavily tested arm positions and exactly which structural thickening of the capsule provides the primary restraint for each.
Okay, let's do it.
And remembering our rule, we're going to state every position and ligament twice. So let's start with the arm in its most neutral state, resting right down at the side.
Position 1, the arm is adducted, hanging straight down at the side of the body. Think of a patient standing with a heavy suitcase in their hand.
Okay, arm straight down.
In this position, the forces trying to pull the arm down, basically subluxing it out of the socket, are inferior forces, gravity and the weight of the limb.
Makes sense.
The primary restraints resisting that inferior pull are the superior glenohumeral ligament, which we call the SGHL, and the coracohumeral ligament, the CHL.
Okay, so arm adducted at the side, resisting inferior pull. The restraints are the SGHL and the CHL. Let's repeat that exactly.
Arm adducted at the side, resisting inferior pull. The primary restraints are the superior glenohumeral ligament, the SGHL, and the coracohumeral ligament, the CHL. And there's a nuanced detail here that the exam loves. Of those two structures, the coracohumeral ligament, the CHL, is actually biomechanically the stronger structure.
Really?
Yeah, it originates from the base of the coracoid and acts almost like a suspension bridge over the top of the joint, enveloping the biceps tendon.
Oh, that's a great visual.
Furthermore, in this adducted position, these two ligaments don't just resist inferior pull, they also act to resist external rotation.
So if you try to externally rotate a patient's arm while it's pinned to their side, it's the SGHL and CHL that get tight.
Exactly.
Okay, got it. Adducted at the side equals SGHL and CHL to prevent the arm dropping inferiorly. Now, let's start moving the arm in space. What happens when we bring the arm up to mid-elevation?
So it's position 2. The arm is at 45 degrees of abduction. We've moved it away from the body halfway to the horizontal plane.
Okay.
At 45 degrees of abduction, the mechanics shift. The joint is now primarily vulnerable to anterior translation, basically the humeral head wanting to slide forward out the front of the socket.
And what stops it?
The primary restraint stepping up to take over the work here is the middle glenohumeral ligament, the MGHL.
Let's lock that one in.
Yeah.
Position 2, 45 degrees of abduction, resisting anterior translation. The primary restraint is the middle glenohumeral ligament, the MGHL.
Perfect.
Repeating again, 45 degrees abduction, resisting anterior translation. The primary restraint is the MGHL.
Now we move to the big one, the most heavily tested biomechanical position on the entire FRCS paper.
Oh boy. Position 3, the danger zone.
Position 3, 90 degrees of abduction combined with extreme external rotation.
The ABR position.
Exactly, the ABR position, abduction, and external rotation. Think of the classic late cocking phase of throwing a baseball, or the exact position your arm is in when you're winding up to spike a volleyball at the net.
Or reaching back to make a tackle in rugby.
Right. In this high-risk ABR position, the kinetic force is driving the humeral head violently forward and slightly down.
Then the restraint.
The primary restraint resisting this massive anterior translation is a very specific thickened band of tissue, the anterior band of the inferior glenohumeral ligament, the IGHL.
This is critical, so if you're driving, pay close attention. At 90 degrees abduction and external rotation, the ABE position, resisting anterior translation, the primary restraint is the anterior band of the inferior glenohumeral ligament, the IGHL.
We must state this twice because it is paramount to everything that follows.
Go for it.
At 90 degrees of abduction plus external rotation, the ABE position, the primary restraint resisting anterior translation is the anterior band of the inferior glenohumeral ligament.
And why is it so heavily tested?
Because when this ligament fails, when this anterior band violently avulses off its attachment on the glenoid rim, that exact anatomical injury is what we call a Bankart lesion.
Right. So the Bankart lesion is literally just the failure of the primary restraint in position 3.
Exactly.
We'll explore the surgical implications of that shortly. But first, we have to complete our map. We have a fourth position, which is essentially the biomechanical mirror image of the third.
Position 4, 90 degrees of abduction combined with internal rotation, the ABIR position.
Internal instead of external.
Yes. Think of a swimmer pulling their arm through the water, or the follow-through of a golf swing. Because the arm is internally rotated at 90 degrees, the vulnerability shifts completely.
But it's not going forward anymore.
Right. Now the joint is resisting posterior translation, the head wanting to slide backward out the back of the joint. The primary restraint taking over here is the posterior band of the inferior glenohumeral-ligament.
Let's state position 4 twice. At 90 degrees abduction and internal rotation, the ABIR position, resisting posterior translation. The primary restraint is the posterior band of the IGHL.
One more time.
Repeating 90 degrees abduction plus internal rotation, resisting posterior translation. The primary restraint is the posterior band of the IGHL.
If you step back and look at the functional anatomy of the IGHL complex, the evolutionary logic is incredibly elegant.
How so?
The inferior glenohumeral ligament isn't just a simple string. It acts exactly like a complex three-dimensional hammock suspended underneath the humeral head.
I really want listeners to visualize this. If you're listening, picture a thick, heavy canvas hammock strung beneath the ball of the joint.
Yeah, that's it.
And to reinforce the hammock, it has 2 thick, heavy-duty ropes stitched into its edges, 1 thick band at the front anterior edge, and 1 thick band at the back posterior edge.
Precisely. It's a hammock with an anterior band and a posterior band, with a thinner axillary pouch slung between them.
Okay, I see.
When you bring the arm up to 90 degrees and you externally rotate it, the entire hammock complex swings forward and twists. That thick anterior band tightens up like a bowstring across the front of the joint to catch the humeral head.
Oh, that makes so much sense.
Right. And conversely, when you're at 90 degrees and you internally rotate the arm, the hammock swings and twists backward, and that thick posterior band tightens up to catch the head.
Wow.
Because it acts like a dynamic hammock, the IGHL complex as a whole is always the primary check-rein whenever the arm is elevated at 90 degrees of abduction. It just depends on which way you're twisting to dictate which band takes the load.
That's a phenomenal visual. If you're externally rotated, the front edge of the hammock, the anterior band, catches you. If you're internally rotated, the back edge of the hammock, the posterior band, catches you.
It turns a dry anatomical list of ligaments into a mechanical working reality you can actually see in your mind's eye.
And being able to see it means you don't have to blindly memorize it. When you get a question about a patient falling on an internally rotated arm, you just visualize the hammock swinging backward. You know the posterior band is tight. You've got the answer.
You can just work it out from first principles on the exam paper.
Which brings us to the end of our restraint map and our golden rule.
If you only remember one thing from this topic, at 90 degrees abduction and external rotation, the anterior band of the IGHL is the primary anterior restraint, and its avulsion is the Bankart lesion.
Yeah. Okay, because that 90-degree ABR position causing a Bankart is the single most common failure we see in trauma bays across the world. It entirely dictates how we must approach the clinical pathology.
It's the big one.
Yeah, we're moving out of normal anatomy and into pathology. Let's break down anterior instability.
Traumatic anterior instability is the absolute bread and butter of shoulder pathology. It's the most common presentation you will see in the clinic, and accordingly, it's the most heavily and rigorously tested presentation in the FRCS.
We need to build out the precise pathology of the failure, starting with the soft tissues.
Right.
So let's set the scene. A 22-year-old patient is tackled on the rugby pitch. Their arm is forced up and out into extreme abduction and external rotation.
The ABE position.
The kinetic energy exceeds the tensile strength of the tissues, and the shoulder dislocates anteriorly. We just established that the anterior band of the IGHL is the hammock rope that fails. Define the exact soft tissue injury that occurs at that moment.
The essential defining lesion of traumatic anterior instability is the Bankart lesion. Anatomically, a true classic Bankart lesion is defined as the physical avulsion, the traumatic tearing away of the anteroinferior labrum alongside the attached anterior band of the IGHL.
And it rips off what?
Ripping right off the bony anteroinferior rim of the glenoid. It is a combined labral and capsule ligamentous failure. The ankle point has pulled out of the bone.
Let me state that again just for clarity. A Bankart lesion is the avulsion of the anteroinferior labrum alongside the attached anterior band of the IGHL. So that covers the soft tissue side.
The hammock tore off the wall.
But the exam loves to test the bony collateral damage that happens in those milliseconds during that same traumatic dislocation. Let's talk about the bone lesions, specifically starting on the humeral head.
This is where we get into the violent biomechanics of a dislocation. When the humeral head blasts anteriorly out of the socket, it doesn't just sit there peacefully.
I imagine not.
The massive muscles of the shoulder, the pectoralis major, the latissimus go into severe immediate spasm.
Oh, right.
That muscle spasm forcefully pulls the dislocated humeral head back against the hard, sharp cortical rim of the anterior glenoid.
But the head is out of the socket.
Exactly. Because the front of the humerus is entirely out of the joint, it's the back of the humeral head that strikes the front of the glenoid.
Wow.
This violent collision causes a compression or impaction fracture on the posterior aspect of the humeral head. This specific bony impaction fracture is called a Hill-Sachs lesion.
It's like taking a wooden ball and smashing it against the edge of a metal pipe. It leaves a dent.
A permanent dent.
So to repeat, a Bankart lesion is the soft tissue tear on the front of the socket, and a Hill-Sachs lesion is the bony dent on the back of the ball. Now, let's bring in the radiographic statistic.
These are important.
Because we aren't just talking about a first-time dislocator. We often deal with chronic, recurrent instability. There's a very striking set of numbers regarding chronic traumatic anterior instability that candidates must know.
The exam explicitly wants you to know that bony damage is incredibly common. It is not rare.
Okay, hit us with the numbers.
In fact, in patients with chronic recurrent traumatic anterior instability, up to 95% of those shoulders will show a macroscopic bony abnormality on plain radiographs or CT scans.
95%.
Up to 95%. Let me break that down for you. Roughly 75% of these chronic patients will have a visible Hill-Sachs impaction fracture on the humeral head, and about 85% will have some form of bony glenoid lesion, where the anterior rim of the socket has been physically worn away, eroded, or fractured off over time.
So the critical takeaway for the listener here is that bone lesions are the rule. They are not the exception in recurrent instability. Let me state those stats twice. Up to 95% have a bony abnormality, 75% have a Hill-Sachs, 85% have a bony glenoid lesion. And this naturally leads us to a massive surgical decision point, the escalation of treatment. If bone loss is the rule in chronic patients, at what point does it completely alter our surgical plan?
This is a classic FRCS branching point. It's the difference between passing and failing the VIVA.
Let's hear.
If a patient only has a soft tissue Bankart tear and their bone is pristine, you can perform an arthroscopic Bankart repair. You place suture anchors into the glenoid rim and essentially sew the labrum and the IGHL back to the bone.
Okay, straightforward.
However, if there is significant glenoid bone loss, usually defined in the literature as greater than 20 to 25% of the glenoid with missing a soft tissue, Bankart repair alone is fundamentally doomed to fail.
Doomed to fail? Why?
You're trying to tie soft tissue to missing bone. You haven't restored the bony arc. The joint will simply slide over your repair and dislocate again.
So if the soft tissue operation is off the table because the bony foundation is gone, what is the escalation?
You must abandon the soft tissue operation and move to a bone block operation. The gold standard procedure for significant anterior glenoid bone loss is a Latarjet procedure.
Latarjet. Let me say that again. A Latarjet procedure for anterior glenoid bone loss.
Right. This involves surgically osteotomizing or cutting the coracoid process, a prominent piece of bone from the scapula, and transferring it, along with its attached conjoined tendons, down to the front of the glenoid.
You physically move the bone.
Yes. You screw it into place to physically rebuild the missing bone and provide a physical structural block to anterior dislocation.
A bone transfer to fix bone loss makes perfect mechanical sense. But it's a much bigger, more complex open operation. And in the exam, any major procedure comes with a specific, highly tested anatomical hazard.
Of course.
What is the key nerve at risk during a Latarjet procedure?
The nerve at absolute greatest risk during a Latarjet is the musculocutaneous nerve.
The musculocutaneous nerve.
The reason is pure, unforgiving anatomy. The musculocutaneous nerve enters the coracobrachialis muscle, which is one of the tendons attached to your coracoid graft, just a few centimeters distal to the tip of the coracoid process, usually about 5 to 8 centimeters down.
Oh, so it's right there in the way.
Because you are dissecting, mobilizing, and physically transferring that coracoid block, the musculocutaneous nerve is directly in your surgical field, tethering the graft. If you pull too hard, you stretch it. If your retractor slips, you crush it.
That's terrifying.
And you also must remember that the axillary nerve is at risk later in the procedure, particularly during any inferior capsule work or when dissecting along the inferior neck of the glenoid to place your screws.
So for a Latarjet, the musculocutaneous nerve is the primary risk up high near the corpus brachialis, and the axillary nerve is at risk inferiorly.
Correct.
Let's state that twice to be safe. Musculocutaneous nerve at risk during coracoid mobilization in a Latarjet. Axillary nerve at risk during inferior glenoid exposure. Now, I want to set up an absolute classic exam trap. This is a scenario question that catches so many registrars out because their clinical intuition betrays the literature.
Let's hear it. This is exactly what the exam tests: intuition versus evidence.
You have a 19-year-old rugby player who has just suffered their first traumatic anterior shoulder dislocation. They are brought into the emergency department, the shoulder is reduced, and the patient is highly anxious about it happening again. They want to know what they can do to prevent it.
Very common scenario.
The clinical question asks for the most significant factor affecting their risk of recurrence. The candidate thinks, well, they're a young collision athlete, and if we don't heal that anterior capsule properly, it's going to tear again. So doesn't immobilizing this 19-year-old shoulder strictly in a sling for 3 to 4 weeks significantly lower their recurrence rate compared to just giving them a sling for a few days for comfort?
It sounds so logical, doesn't it? Immobilize it, let it scar, let it heal.
Right.
But the exam will brutally shoot this down. The answer is absolutely not. The single biggest predictor of shoulder dislocation recurrence is not the post-reduction treatment. It is not the type of sport they play.
Wait, really?
It is the age of the patient at the time of their first dislocation. Age at first dislocation is the sole, overwhelming driving factor for recurrence.
Let me push back on that.
Yeah.
Because surely 3 weeks of strict immobilization in internal rotation does something to help the tissues heal tighter. I mean,
Prospective randomized clinical studies have proven that 3 weeks of strict immobilization in a sling makes zero statistical difference to the long-term recurrence rate compared to just a few days of rest until the acute pain settles.
zero difference.
Zero. Furthermore, whether they play a collision sport like rugby or a non-contact sport, it doesn't fundamentally alter the baseline physiological risk. Their gender doesn't change the outcome. The only thing that truly drives the statistics is how old they were when that joint popped out for the very first time.
Give us the hard numbers to back that up and explain why that is. Why does a 19-year-old fail again when a 45-year-old doesn't?
If a patient is under 20 years old at the time of their first dislocation, their recurrence rate is quoted in the literature as being between 70 to 100%. It is virtually guaranteed to dislocate again regardless of how long you rest it.
70 to 100%.
However, if the patient is over 40 years old at the time of their first dislocation, the recurrence rate plummets to roughly 15 to 20%.
That's a massive drop.
And the biological mechanism, the why, comes down to collagen elasticity. A 19-year-old has highly elastic collagen. When their shoulder dislocates, the capsule doesn't just cleanly snap, it stretches, it plastically deforms, and it permanently elongates before it finally tears off the bone.
So it stretches out like an old rubber band.
Exactly. When it eventually heals, it heals baggy and loose. A 40-year-old has stiffer, more brittle, cross-linked collagen. It doesn't stretch, it just snaps. And when you repair a clean snap, or when it scars down, it heals tight. That's why young age drives recurrence.
That makes perfect sense when you explain the plastic deformation of the collagen. It's a phenomenal exam trap to avoid. Let me say it again for the listeners. Do not pick immobilization. Pick age.
Yes, age is the answer.
Which brings us to the end of our anterior instability section.
If you only remember one thing from this topic, the Bankart is the antero-inferior labrum plus IGHL avulsion. Significant glenoid bone loss pushes you to a Latarjet, watching the musculocutaneous nerve, and recurrence is driven by young age.
Excellent. Now, if you're listening, wherever you are, keep your hands on the steering wheel, keep chopping those vegetables. We're going to pause the new information right here. Before we move on to the weird and wonderful ways the shoulder dislocates backwards or in multiple directions, let's just make sure our mental map is crystal clear up to this point.
Good idea.
We're going to explicitly and clearly summarize the core facts from the first 3 sections. We won't rush this. We're going to reiterate the positions and ligaments to aid your audio-only retention.
Let's consolidate the map.
First, we have 2 families of stabilizers. The static stabilizers are the passive structures: the glenoid labrum, the capsule, the glenohumeral-ligaments, and the negative intra-articular pressure.
Spot on.
The dynamic stabilizers are the active muscles: The rotator cuff is the primary dynamic stabilizer. The biceps is secondary. Do not let them trick you into calling the labrum dynamic.
Next, the position to ligament map. Arm adducted at the side, resisting inferior pull. The restraints are the SGHL and the CHL. Stating it twice, arm adducted, resisting inferior pull, SGHL and CHL.
Moving up to 45 degrees of abduction, resisting anterior translation. The primary restraint is the MGHL. Stating it twice, 45 degrees abduction, anterior restraint is the MGHL.
The throwing position. 90 degrees of abduction plus external rotation, the ABER position, resisting anterior translation. The primary restraint is the anterior band of the IGHL. Stating it twice 90 degrees abduction plus external rotation, anterior restraint is the anterior band of the IGHL. Remember, this is the Bankart position.
And the mirror image. 90 degrees of abduction plus internal rotation, resisting posterior translation. The restraint is the posterior band of the IGHL. Stating it twice 90 degrees abduction plus internal rotation, posterior restraint is the posterior band of the IGHL.
Finally, anterior instability pathology. A Bankart lesion is the avulsion of the anteroinferior labrum and the anterior band of the IGHL. A Hill-Sachs lesion is the bony impaction fracture on the posterior humeral head.
Up to 95%.
Right. Up to 95% of chronic recurrent cases have bony abnormalities. Significant anterior glenoid bone loss requires a Latarjet bone block procedure where the musculocutaneous nerve is at high risk. And the single biggest predictor of recurrent dislocation is young age at first dislocation due to collagen elasticity.
That is the first half of the map securely locked in. But as we pivot to the second half, we need to recognize that while anterior instability is incredibly common, the FRCS exam absolutely loves to test the rare, bizarre, and often devastating failures of the shoulder joint.
They really do.
We are moving into posterior and multidirectional instability, or MDI.
This is a crucial transition. This is where we contrast the typical athletic trauma of an anterior dislocation with the highly specific, often pathological mechanisms that drive the shoulder out the back or everywhere at once.
Let's start with the shoulder dislocating directly backwards. Posterior instability. What triggers this? It's not a typical rugby tackle or a fall on an outstretched hand, is it?
Very rarely. While you can get a posterior dislocation from a direct blow to the front of the shoulder, the classic, heavily tested trigger for a posterior dislocation requires a massive, uncoordinated bilateral muscle contraction.
Like what?
The exam trigger is almost always a violent seizure or a severe high-voltage electric shock.
Why does a seizure make the shoulder go backward?
It comes down to muscle bulk and leverage. Look at the internal rotator muscles of the shoulder, primarily the subscapularis, the pectoralis major, and the latissimus dorsi.
Okay, big muscles.
Very big. They are significantly bulkier and biomechanically more powerful than the external rotators, the infraspinatus and teres minor. When a seizure or a shock indiscriminately fires every single muscle around the shoulder girdle simultaneously at maximum force, the violent internal rotators completely overpower the external rotators. They forcefully internally rotate the arm, and the sheer compressive force drives the humeral head straight out the back of the socket.
Seizure or electric shock equals posterior dislocation due to overpowering internal rotators. Let me repeat that. Seizure or electric shock equals posterior dislocation. But there is a massive diagnostic trap here that happens in the emergency department, which the exam will definitely test because it's a common area for litigation.
It's the chronically missed diagnosis. A posterior dislocation is notoriously easy to miss on a standard single anteroposterior or AP plane radiograph.
Really? How do you miss a dislocated shoulder?
Because the humeral head is sitting directly behind the glenoid, rather than dropping down like an anterior dislocation, on a straight-on 2D view, it can look perfectly concentric. It looks like it's still in the joint.
Oh, wow.
It creates a symmetrical appearance, often described as the light bulb sign, because the internally rotated head looks like a light bulb. To properly diagnose it and avoid missing it, you absolutely demand a second orthogonal radiographic view, specifically an axillary view, shooting the X-ray from the armpit up.
And that shows it.
Yes, that will clearly show the humeral head sitting completely posterior to the glenoid socket.
So seizure or shock, you must always get an axillary view. Let me state that twice. Always get an axillary view for suspected posterior dislocation. Do not trust the AP view. Now, what about the bony damage? We talked about the Hill-Sachs impaction on the back of the head for an anterior dislocation. What happens when the joint goes posterior?
You get the exact anatomical mirror image. Because the humeral head is dislocated backwards, the front of the humeral head gets violently pulled against the sharp back rim of the glenoid.
The reverse.
Exactly. This creates a deep impaction fracture on the anteromedial aspect of the humeral head. This is called a reverse Hill-Sachs lesion, and in the exam, it is also frequently referred to by its eponym, the McLaughlin lesion.
The reverse Hill-Sachs or McLaughlin lesion on the anteromedial humeral head. Let me say that again, reverse Hill-Sachs or McLaughlin lesion on the anteromedial aspect. So, how do we treat these posterior dislocations? Especially because, since they are often missed initially, they present late and are rigidly locked out of joint.
The treatment algorithm for posterior dislocation is entirely driven by the size of that reverse Hill-Sachs defect on the anteromedial humeral head. It's a strict defect size protocol.
Okay, break it down for us.
If the defect is small, say less than 20% of the articular surface, you can generally manage it with a closed reduction under general anesthesia, pulling it back into place and immobilizing it in slight external rotation.
What if the dent is larger? What if it's been locked out for a week?
If it's a moderate defect, which the literature defines as involving roughly 20 to 40% of the articular surface, simply pulling it back into joint won't work.
Because it's unstable.
Right. The moment they internally rotate, that massive anteromedial dent will engage on the posterior glenoid rim and lever the joint straight back out. You have to fill the pothole.
And how do we do that?
The exam answer here is the modified McLaughlin procedure. You surgically take the subscapularis tendon and its bony attachment, the lesser tuberosity of the humerus, and you physically transfer them directly into the anteromedial defect. You screw it down to fill the space, effectively turning a defect into a solid block.
So the modified McLaughlin fills the moderate 20 to 40% defect. In the final stage of escalation, what if half the head is caved in?
If the defect is massive, meaning it involves greater than 45 to 50% of the articular surface, the humeral head is mechanically unsalvageable. The congruency is destroyed.
So you have to replace it.
Yes. You must move to a joint arthroplasty, typically a hemiarthroplasty or a total shoulder replacement, depending on the patient's age and glenoid wear.
That's a very clean algorithm to memorize. Small defect under 20% is closed reduction. Moderate, 20 to 40%, is the modified McLaughlin transfer of the subscapularis. Large, over 45%, is arthroplasty. Now, let's pivot from the trauma of posterior instability to the complex world of multidirectional instability, MDI.
MDI is a completely different beast, and the exam demands very strict definitions here to distinguish it from standard trauma.
How does it start?
MDI is not caused by a single violent traumatic event like a tackle or a seizure. It occurs in patients who are naturally loose-jointed, often possessing generalized ligamentous laxity or underlying collagen disorders like Ehlers-Danlos or Marfan syndrome.
And how is it definitively diagnosed? Because a patient might just say their shoulder feels loose.
To diagnose true multidirectional instability, the instability must involve symptomatic subluxation or dislocation in multiple planes, anterior, posterior, etc. But crucially, it must include an inferior component.
Inferior.
Inferior translation is the absolute hallmark of MDI. You demonstrate this clinically by checking for a positive sulcus sign.
Let's define that maneuver. You pull the arm straight down towards the floor, and a physical groove or sulcus appears in the skin just below the lateral edge of the acromion bone, because the whole humeral head has sagged downwards out of the socket.
Exactly.
That is the positive sulcus sign indicating severe inferior laxity. Let me repeat it. The positive sulcus sign indicates inferior laxity, which is the hallmark of MDI.
Precisely. Because MDI is a condition of generalized systemic laxity, it is fundamentally a dynamic control problem and a proprioceptive deficit.
So the ligaments are useless.
Yes. The static stabilizers, the capsular ligaments, are inherently stretched, redundant, and mechanically useless from birth. Therefore, you cannot rush in to surgically tighten them. The absolute gold standard first-line treatment for MDI that you must select on the exam is always physiotherapy.
Always physiotherapy. Tell us exactly what that physio entails, because physio is a broad term.
It must be a dedicated, prolonged, highly specific program lasting a minimum of 6 months, focused entirely on strengthening the dynamic stabilizers.
The muscles again?
Yes. You are prescribing intensive rotator cuff strengthening and periscapular muscle stabilization. You are literally trying to retrain the muscles to fire earlier and harder to do the job the loose ligaments cannot do. You treat the dynamic stabilizers first.
Okay, physio for 6 months. I'm repeating that, physio for 6 months first. But what if 6 months of strict compliant physiotherapy fails, and the patient is still painfully subluxing their shoulder, just reaching for a glass of water? What is the surgical option for MDI?
If surgery is completely unavoidable, the goal is to globally reduce the shear volume of the stretched joint capsule.
Like taking in a baggy shirt.
Exactly. The overarching procedure is an inferior capsular shift, where you essentially tailor the capsule to make it smaller. However, there is one highly specific surgical maneuver you must know for the exam. To combat that hallmark inferior and posterior translation, you must close the rotator interval.
Define the rotator interval for us anatomically.
The rotator interval is a triangular anatomical gap in the upper front part of the shoulder capsule. It is bordered superiorly by the leading edge of the supraspinatus tendon and inferiorly by the superior edge of the subscapularis tendon. The base is the coracoid.
What's inside it?
Inside this interval runs the long head of the biceps, the coracohumeral-ligament, and the superior glenohumeral-ligament. In MDI patients, this capsular gap is often patulous and extremely wide.
And closing it helps.
By surgically suturing this gap closed, pulling the supraspinatus and subscapularis edges together and closing the rotator interval, you effectively tighten the entire capsular structure against inferior and posterior sliding.
Closing the rotator interval, the gap between supraspinatus and subscapularis, to tighten a joint against inferior laxity. Let me state that twice close the rotator interval for MDI surgery. Brilliant. That covers the rare and the complex. Let's hit the rule.
If you only remember one thing from this topic, posterior dislocation follows seizures or shocks, needs an axillary view, and gives a reverse Hill-Sachs. Multidirectional instability includes an inferior component and is treated first with physiotherapy.
So we know how to identify and fix a real traumatic tear like a Bankart, and we know how to rehab a loose MDI joint. But what about things that look exactly like tears on an MRI or through an arthroscope, but are actually completely natural?
Ah, the traps.
Yes. This brings us to normal variants and SLA lesions.
I cannot emphasize this enough to candidates. This section is pure exam gold. The examiners are obsessed with ensuring you can confidently recognize normal anatomical variants.
Why are they so obsessed?
Because the most catastrophic amateur error a junior surgeon can make is falling into the psychological trap of fixing something that isn't broken.
Let's talk about the most famous trap of all, the Buford complex.
The Buford complex is a recognized, naturally occurring anatomical variant present in roughly 1.5% of all shoulders. It's a congenital quirk of how the tissues separate during embryonic development.
What's it look like?
It consists of two simultaneous, distinct features. First, the anterosuperior portion of the labrum, the upper front quadrant, is completely absent from birth. It is just bare, smooth glenoid bone.
Okay, no labrum there.
Second, to mechanically compensate for that missing labrum, the middle glenohumeral-ligament, the MGHL, is extraordinarily thick. It looks like a dense, fibrous cord running diagonally across the joint from the upper glenoid down to the humerus.
So absent anterosuperior labrum, combined with a thick, cord-like MGHL, I'll state that again, absent anterosuperior labrum with a cord-like MGHL. Now, put us in the operating room. I want to understand why this is such a dangerous pitfall. You're looking through the arthroscope, the camera's in the back of the shoulder, looking forward at the anterior joint. What is the visual trap?
The trap is psychological as much as it is visual. You are a surgeon. You are in there to find and fix tears. You look at the anterosuperior quadrant and you see a massive gap where the labral bunker should be. And right next to it is this thick, ropey tissue that looks exactly like a labrum that has been traumatically ripped off the bone and displaced medially.
I can see how you'd want to fix that.
The overwhelming, almost instinctual urge is to grab that thick MGHL cord with your grasper, place an anchor into the bare bone, and stitch the cord down to repair the gap and recreate the bumper.
But the expert rule is you must not repair it.
Yes.
What happens if you give in to that urge, place an anchor, and sew it down?
It is a surgical disaster for the patient because that thick cord is not a torn labrum, it is the MGHL. And as we learned in our restraint map, the MGHL's job is to restrict anterior motion at 45 degrees of abduction and external rotation.
Oh, no.
If you artificially pin that mid-substance ligament tightly to the glenoid bone, you completely tether the joint. You essentially tie the humerus to the scapula. The patient will wake up and you will have severely, permanently restricted their external rotation and elevation.
A completely stiff shoulder.
They will have an incredibly stiff, essentially frozen shoulder, entirely caused by your misguided surgery.
Wow. So the rule is absolute. Recognize the Buford complex and leave it alone. Do not repair it. Now, is there another normal variant in that exact same upper quadrant we need to watch out for?
Yes, the sublabral foramen. This is also located in the anterosuperior quadrant between the 1 o'clock and 3 o'clock positions.
How is it different?
In this variant, the labrum is actually present, but it is not attached to the underlying glenoid bone. It creates a small gap or a hole beneath the labrum, like a bucket handle. Just like the Buford complex, this is entirely normal. It does not cause instability, and it must be left completely alone.
Which brings us to a beautiful, simplifying golden rule for the exam regarding labral detachments.
How do I know when to sew and when to walk away?
The golden rule to remember: if you see an anterosuperior labral detachment or gap up at the top front, it is overwhelmingly likely to be a normal variant, like a Buford complex or sublabral foramen. Do not touch it.
Up top, leave it alone. However, if you see an anteroinferior detachment down at the bottom front corner, the 3 o'clock to 6 o'clock position, that is a real pathological Bankart lesion, and that is what you absolutely must repair. Anterosuperior equals normal variant. Anteroinferior equals real Bankart.
That is a fantastic shortcut. I'll state it twice. Anterosuperior variant, anteroinferior Bankart. One more time: anterosuperior variant, anteroinferior Bankart. Now, before we leave the labrum entirely, we have to touch on a true pathological lesion that happens right at the top of the joint, the SLAP lesion.
Right. SLAP stands for superior labrum anterior to posterior. This is a true tear of the superior labrum stretching from front to back, right exactly where the long head of the biceps tendon anchors into it at the top of the glenoid.
Who gets these?
It is incredibly common in overhead throwing athletes, like baseball pitchers or javelin throwers. It's caused by a peel-back mechanism. The extreme torsional forces pulling on the biceps anchor during the late cocking phase of throwing physically peel the superior labrum off the bone.
What are the two specific exam pearls regarding SLAP lesions?
First, a chronic SLAP creates a one-way valve that allows joint fluid to leak out of the capsule and form a paralabral cyst, specifically a sphenoglenoid cyst.
Sphenoglenoid cyst.
Yes. Because of its location in the sphenoglenoid notch at the back of the scapula, this enlarging cyst can mechanically compress the suprascapular nerve as it winds around the notch.
And what did that do?
This compression leads to isolated weakness and atrophy of the infraspinatus muscle. The patient presents with poor external notation strength, but normal supraspinatus strength.
That's a great anatomical connection. Sphenoglenoid cyst compressing the suprascapular nerve affecting the infraspinatus. Let me repeat that. Sphenoglenoid cyst compressing the suprascapular nerve. And what is the second pearl?
Second is the treatment trap regarding the patient's age. If a 20-year-old elite athlete has a traumatic SLAP tear, you might perform an arthroscopic SLAP repair, placing anchors and sewing the labrum and biceps anchor securely back down to the bone to restore their throwing mechanics.
Okay, young patient, fix it.
However, the exam will invariably give you a 55-year-old manual laborer with a degenerative SLAP tear. In older patients, a formal SLAP repair is generally contraindicated because their tissues are stiffer, and sewing the biceps anchor down causes unacceptably high rates of postoperative stiffness and chronic pain.
So what's the solution for the 55-year-old?
For the older patient, you should abandon the anatomical repair and instead favor a biceps tenodesis.
A biceps tenodesis.
You surgically cut the biceps tendon completely off the damaged superior labrum, take it out of the joint, and re-anchor it further down on the humerus. This removes the mechanical pain generator pulling on the torn labrum without artificially stiffening the joint capsule. SLAP repair for the young, biceps tenodesis for the older patient.
Excellent logic. Let me repeat that one. SLAP repair for the young, biceps tenodesis for the older patient. Which brings us to the end of the variants.
If you only remember one thing from this topic. The Buford complex, a cord-like MGHL with an absent anterosuperior labrum, is a normal variant you must never repair. Anteroinferior detachment is the real Bankart.
Okay, we are at our second required pit stop. Before we get into the clinical exam tests, we're going to explicitly summarize the core facts from the sections we just covered on MDI, posterior instability, and variants. This is your chance to solidify this information.
Let's run back through it.
Let's do it.
Posterior and multidirectional instability. Posterior dislocations are triggered by seizures or electric shocks due to violent, overpowering internal rotators. They absolutely require an axillary view to diagnose, and they create a reverse Hill-Sachs or McLaughlin lesion on the anteromedial humeral head.
Got it. And for MDI, multidirectional instability must include an inferior component clinically proven by a positive sulcus sign. The absolute first-line treatment for MDI is a minimum of 6 months of physiotherapy to train the dynamic stabilizers. Stating it twice, MDI is treated first with expensive physiotherapy for the dynamic stabilizers.
Moving to normal variants. The Buford complex is an absent anterosuperior labrum with a thick, cord-like MGHL. The absolute prohibition: you must never repair it, or you will tether the joint and cause devastating stiffness.
Stating it twice, the Buford complex is an anterosuperior variant. You must never repair it.
The sublabral foramen is also an anterosuperior gap, also left alone. Remember the anatomical rule: anterosuperior gap equals normal variant. Antero-inferior detachment equals real Bankart.
And SLAP lesions.
Finally, SLAP repairs are contraindicated in older patients. Use a biceps tenodesis instead to prevent stiffness.
So we know the gross anatomy, we know the pathology, and we know the surgical traps. But how do we actually prove what is going wrong when the patient is sitting in front of us in the outpatient clinic?
Exactly. We need to translate this anatomy into physical clinical signs.
We're moving into the instability examination tests. I want you to walk us through the physical examination maneuvers used to differentiate these pathologies in a clinical scenario.
Let's start with the most important test for the most common problem, the apprehension test for anterior instability. To perform this, the patient is usually supine. You take the patient's arm and place it into that exact high-risk biomechanical position we discussed in our map.
The ABER position.
Yes. You bring the arm up to 90 degrees of abduction, and you gently, slowly push them into maximum external rotation, the ABER position.
And what exactly are we looking for? Because they've had a previous dislocation, so it's probably going to hurt, right?
You are watching the patient's face, not just their shoulder. As you rotate the arm back, the humeral head physically translates and presses against the damaged anterior capsule. In a patient with true anterior instability, they will feel a terrifying sensation that their shoulder is physically about to pop out of the socket right then and there.
I see.
They will flinch, their muscles will involuntarily go into spasm to stop your hand from pushing further, and they will express severe apprehension. Apprehension, that visceral feeling of impending dislocation, is the true positive sign.
Now, this leads to a critical diagnostic distinction. What if you put them in that position and a patient doesn't flinch, they don't feel like it's going to pop out, but they just say, ouch, that hurts deep inside?
That is precisely the nuance the FRCS tests. Pure pain is not a positive apprehension test. Pain alone could mean a multitude of things, most commonly internal impingement or a SLAP tear.
So how do you tell?
To truly differentiate true capsular instability from impingement syndrome, we use a follow-up maneuver called the relocation test.
Describe the mechanics of the relocation test.
While the patient is in that ABE position, feeling that intense apprehension and guarding, you take your other hand and apply a firm, direct, downward posterior pressure on the front of the proximal humerus. You are physically pushing the humeral ball backward, securely centering it into the socket.
And then what?
If the patient has true anterior instability, pushing the head back into place will instantly resolve their feeling of apprehension. They will visibly relax, the muscle guarding stops, and you can usually rotate their arms significantly further back into external rotation without resistance.
So, if the relocation test relieves the apprehension, it definitively proves it was an instability problem. Let me repeat that twice. Apprehension relieved by posterior relocation means anterior instability. Apprehension relieved by posterior relocation means anterior instability.
Exactly. But if you apply that firm posterior relocation pressure, and it does not relieve any apprehension, but instead just causes more pain deep in the joint because you're compressing inflamed tissues, the patient does not have primary instability.
They have impingement.
They are much more likely suffering from impingement. Apprehension relieved by posterior pressure equals instability.
That is incredibly clear. Apprehension relieved by relocation. Now, what about proving the inferior laxity we discussed earlier for multidirectional instability?
We covered this briefly, but it is the sulca sign. With the patient seated and their arm resting neutrally at their side, you grasp their elbow and apply a straight, steady, inferior traction, pulling the whole arm down toward the floor.
Just pulling straight down.
If they have inferior capsular laxity, the humeral head will translate downwards, and a visible hollow or sulcus will appear between the lateral edge of the acromion and the top of the humeral head. A positive sulcus sign proves the inferior laxity necessary to confirm an MDI diagnosis.
Repeating the sulcus sign, a positive sulcus sign proves inferior laxity. And lastly, how do we manually gauge the actual physical amount of sliding back and forth in a patient who is awake?
We use the load and shift test. The patient can be seated or supine. You grasp the humeral head with one hand, stabilizing the scapula with the other. You first load the joint by gently compressing the humeral head directly into the glenoid to center it.
Okay, load it.
Then you shift it by applying a translating force directly anteriorly and then directly posteriorly. This allows the examiner to manually feel the endpoint and grade the exact degree of anterior and posterior translation relative to the glenoid rim. Is it translating up to the rim, over the rim, or locking out?
So, load and shift for grading translation, sulcus sign for inferior laxity, and the apprehension relocation combo for anterior instability versus impingement. Let me say those one more time. Load and shift for grading translation, sulcus sign for inferior laxity, and the apprehension relocation combo for anterior instability versus impingement.
If you only remember one thing from this topic, apprehension relieved by posterior relocation means anterior instability. A sulcus sign signals the inferior laxity of multidirectional instability.
All right. If you're listening, we have reached the end of the deep dive explanatory material. You've made it through the dense anatomy. But before we finish, we are going to run a final lightning round.
The best part.
This is a rapid-fire lab to lock in the absolute highest yield facts one last time before you walk into that exam hall. I will ask the question, and we will give you the precise single-sentence answer, no fluff.
Let's do it.
What is the primary dynamic stabilizer of the shoulder?
The rotator cuff. Remember, the labrum and ligaments are static.
With the arm adducted at the side, what is the primary restraint to inferior translation?
The superior glenohumeral-ligament and the coracohumeral-ligament, the SGHL and CHL.
With the arm at 90 degrees of abduction and external rotation, what is the primary anterior restraint?
The interior band of the inferior glenohumeral-ligament. This is the Bankart position.
What is the single biggest predictor of recurrence following a first-time traumatic anterior dislocation?
Age at first dislocation. The younger the patient, the higher the risk of recurrence due to collagen plasticity.
What percentage of chronic anterior instability cases show a bony abnormality on radiographs?
Up to 95%.
What is the nerve at greatest risk during a Latarjet procedure?
The musculocutaneous nerve, near the coracobrachialis.
What is the classic triad for a posterior dislocation?
Caused by a seizure or shock, requires an axillary view to diagnose, and produces a reverse Hill-Sachs lesion.
What is the first-line treatment for multidirectional instability?
Physiotherapy, specifically strengthening the dynamic stabilizers for a minimum of 6 months.
What is the absolute surgical rule regarding the Buford complex?
It is a normal variant. Leave it alone. You must never repair it.
In the clinical exam, apprehension that is completely relieved by posterior pressure indicates what?
True anterior instability. That is a positive relocation test.
And that concludes the lightning round. So let's summarize our thesis for this entire session. Shoulder instability is a map. It's an elegant geographical system.
It really is.
If you take the time to learn which specific ligament holds the line in which exact position, everything else falls into place. Anchor your entire understanding around that critical 90-degree external rotation Bankart position, and let all the other pathology and clinical tests hang off that central concept.
It really is a system of structural logic, not just a list of facts. But I want to leave you with a final, slightly provocative thought to mull over as you finish your drive or your tasks, something that bridges the gap between today's topic and your future revision.
Go ahead.
We spent a lot of time today talking about how the rotator cuff is the primary dynamic stabilizer. It actively holds the humeral head perfectly centered in the socket via concavity compression. I want you to think about what happens biomechanically when that cuff starts to age, degenerate, and eventually tear as a patient reaches their 60s or 70s.
Right, because it doesn't last forever.
Exactly. Without that dynamic center of gravity constantly pulling the head down and in, the massive deltoid muscle takes over. The humeral head starts to slowly migrate superiorly, sliding upwards out of the socket. And suddenly, you are no longer just dealing with a simple instability problem.
What's it become?
You're dealing with chronic impingement, the wearing away of the acromine, and eventually profound joint-destroying arthropathy.
It's all connected. A failure of stability inevitably becomes a failure of the entire joint mechanics, which is exactly why the failing rotator cuff, impingement syndrome, and arthropathy will be the primary focus of our very next session. Thank you for joining us for this revision deep dive. Keep mapping out those structures, trust the anatomy when you're in the exam, and we will see you next time.
Best of luck with your revision.